So today I'm going to spend time walking you through the data as it comes to safety. I know there's been a lot of discussion, a lot of buzz, a lot of energy around safety-related issues. So I'm going to walk you through it, a deep dive of the data, so we can understand what what the science tells us. I do not have proprietary stake in the company or the investigational product. I'm going to walk you through the adverse event rates, the laboratory abnormalities, vital signs, ARIA-E and ARIA-H, which are events of interest, and infusion-based reactions. As Mike Irizarry told you, this was a very carefully monitored study with the DSMB that had continuous input at all times. And so the rigor of the science and the safety were always there, and we'll kind of work through that. My first thing I want to talk to you about is this slide. And I actually ask you to first go to the footnote. And what I want to show you here is that the causes of death are in the footnote. And if you read the Lecanemab group, it's death, cerebrovascular accident, myocardial infarction, respiratory failures, metastasis, meningitis, COVID-19. And if you look at the placebo group, there was respiratory failure, myocardial infarction, metastasis to bone, macrohemorrhage, intracranial hemorrhage, COVID, and pancreatic cancer. I'm starting here because I want to make the point that in the randomized placebo-controlled trial, the 301 study, there were no ARIA-related deaths in treated group. Okay, none, and no cause of death related to ARIA. If you actually then look back through the rest of it, you see that the SAE rate is pretty similar between the treated and the placebo group, except for the ARIA-related SAEs. And if you take out the ARIA-related SAEs and infusion-related SAEs, you see that the safety, the SAE rate is effectively the same in both groups. Let me now talk to you about the most common event rates. And so let me first show you, look at the right-hand side of the slide. In baseline and in all the treated visits, there were no differences in laboratory events, EKG, vital sign parameters, or any other notable events. So there the perception, of course, is that Lecanemab, at least from a vital sign standpoint and laboratory standpoint, is generally safe. If you look at the bottom of this slide, you see that the incidence of common things like headache, falls, UTIs, COVID were the same amongst both groups. Again, no heavy predisposition to either one group. And if you look at the top, you see, as expected, there are more infusion-based reactions, ARIA-E, ARIA-H, and I want to point out that fourth line, which is that if you take out ARIA-E combined with ARIA-H, just looking at ARIA-H alone, there is no difference between treatment and placebo in terms of Lecanemab having more ARIA-H. If we look at the immunogenicity and the infusion-related reactions, I first direct you to the bottom of the slide. First thing you notice is that there are very few neutralizing antibodies. Second, that there are only 10% treatment emergent positive anti-drug antibodies with very low titers, and that there were no impact of immunogenicity on efficacy or safety endpoints, meaning that generally there was very little in terms of immunogenicity. When we look at the top right-hand side, you see that the Lecanemab group had more infusion-related reactions, 26% of the cohort. Almost all of them occurred in the first treatment dosing and were mild to moderate, 96%. They only occurred mostly in the first treatment and did not occur in subsequent treatments. And that whether you pre-treated or didn't pre-treat with things like acetaminophen or antihistamine, it did not change the recurrence rate for subsequent treatments. So if you had infusion-based reactions, they almost always occurred with the first dose. This is the slide that everybody wants to talk about, which is the ARIA-E incidence rate. So I'm going to kind of walk you through this because I like numbers The first thing I'm going to show you is that the denominator for ApoE4 carriers is 620 out of 898. That means that the overwhelming majority of the sample were ApoE4 carriers. I say this to you because the 201 study had fewer ApoE4 carriers, and therefore, when you see this, that was always suggesting that we would have differential effects or concerns about safety. And the answer is no, we do not have differential concerns about safety. If you take the ApoE4 carriers, that 620, and break it down, you see that non-carriers only had an ARIA-E incidence rate of 5.4%, and heterozygotes only had an ARIA-E incidence rate of 10.9%, and that 15% was driven a lot by the homozygotes. When you look at it in totality, the ARIA-E rates were mild or to moderate radiographically, which I'll show you in another slide, and were clinically asymptomatic 78% of the time. When they were symptomatic less than 3% of the time, and it was a mild, which we'll talk about, and it would include headache, visual disturbance, and some confusion. Another thing we want to think about is when does the time to event analysis, when does the ARIA rate occur? And the answer is in Lecanemab's treatment, 90% of them occurred within the first 180 days, and a majority of them were in the first 90 days. So we can predict when patients will have enough. If they're going to have it, it'll be in the first 90 to 180 days. An important other thing is that regardless of the ApoE4 carrier status, the majority of them resolved. 54% in 90 days and 81% in 120 days. So we know, again, when are the ARIA events likely to occur, ARIA-E events likely to occur, and when are they likely to resolve? Now let's spend a minute talking through the slide. Again, a lot of numbers in front of you. So you see here that the denominator is 898. The ARIA-E rate for the numerator is 113. And if you look at the radiographic severity, that on the right, on the middle right, that's 37, 66, and 9. That means that the overwhelming majority of the ARIA events were mild or moderate in radiographic severity. And clinically, when they were symptomatic, only 25% were clinically symptomatic, mild to moderate, 10, 12, and 3. So again, the majority of the sample were mild to moderate in clinical severity and mild to moderate in radiographic severity. And when you actually look at in the ApoE4 carriers, you see the same thing, that 98 out of 620 had an ARIA-E related event, and the majority of them were either low, 9.2% for homozygote or 1.7% for heterozygote. Again, low numbers, and so I want to point out to you that it is mild to moderate radiographically, mild to moderately clinically, and is related to ApoE4 carrier status. Microhemorrhages, or ARIA-H, is a little different. As I said before, if you did not have an ARIA-E event, the microhemorrhage rate, or ARIA-H, was essentially unchanged from placebo. And when it did occur, 17% versus 9% in the placebo group occurred, and that most of them were clinically asymptomatic. As you see, symptomatic ARIA-H was only 1.4% of the samples in Lecanemab group versus 0.2% in the placebo group. So again, very minimally symptomatic, and was driven by the ApoE4 carrier status. Now, when we look at the deaths, this is important because this is where all the controversy and excitement and reporting has been. Let me point out that there was one cerebral macrohemorrhage related death that occurred in the randomized study, and it occurred in the placebo group, not in the treated group. So when you actually now add, and all the comments I've made so far are only talking about the randomized study. When we look at the open label study and we add it, we see that there were 2 deaths that occurred with cerebral macrohemorrhage. The first of them was a 65-year-old female ApoE4 homozygote with left middle cerebral artery territory infarction, or occlusion, I should say. This occurred in the open label extension. That patient received TPA, tissue plasminogen activator. My neurology colleagues know that it's a thrombolytic, which means that it has a known complication of a hemorrhage, and the hemorrhage did occur and the patient expired. But it was in the setting of TPA in Lecanemab. The second one was an 87-year-old female, 87-year-old male, ApoE4 non-carrier on Eliquis or Eliquis for atrial fibrillation, who had many falls and pneumonia and developed a macrohemorrhage 4 months after initiation of Lecanemab open label treatment. Eliquis was stopped. The patient subsequently, because he had atrial fibrillation, had a myocardial infarction and died from cardiopulmonary arrest. These cases show that the causality with Lecanemab is a little difficult. And I understand that people want to say that there's some causality. These things are continued to be explored. So the point here is that the rate of macrohemorrhage is low. It's only 0.6 to 0.7% compared to placebo. It does go up with anticoagulation, and that might be a relative risk that needs to be managed, might need to be discussed. We know that there is no clear relationship between macrohemorrhage and ApoE4 carrier status, baseline MRI or timing of treatment, and it will be a caution that patients on anticoagulation might need some further consideration. In summary, Lecanemab was generally well tolerated. Most adverse events were infusion-related reactions, ARIA-H and ARIA-E, and headache. The incidence of ARIA incidence was within expectations and was low, with the ARIA-E rate of about 12.6% in the Lecanemab group versus 1.7% in the placebo. Symptomatic ARIA-E was less than 3%. Most of them occurred within the first 90 to 120 days, or 180 days, and most of them resolved within the first 120 days. ARIA-H was in combination with ARIA-E was a 17% incidence rate, and symptomatic was only 0.7% in the treated group. There was no imbalance when it was isolated ARIA-H alone. And when you looked at them, it was less common ARIA-E and ARIA-H in ApoE4 non-carriers, with higher frequency occurring expectedly in ApoE4 carrier homozygotes versus